Welcome to Nursing Life 101, the most important nursing class you never got to take in nursing school. We will be traversing different objectives like interviewing, what to do in nursing school, boundaries, burnout, and so much more. If this interests you, I hope you are taking good notes because class is now in session.
Hello, and welcome to Nursing Life 101. We're so excited to have you here with us as we dive into the world of nursing, sharing our experiences, insights, and a little bit of fun along the way. I'm Christopher, and I couldn't be happier to introduce my co-host.
Hey guys, it's Colby. Together, we'll be bringing you real stories, practical tips, and discussions about all things nursing. Whether you're a fellow nurse or just curious about life behind the scrubs, we're thrilled to have you join us.
We're definitely not excited about this topic. It's something that needs to be talked about, but it's something that feels very heavy.
Yes, before we started recording, I shared that I was actually kind of scared to do this one. But like Christopher said, despite having these feelings, we also share the feelings that it's imperative that we kind of share this information. So yeah, we'll get down to the nitty gritty.
Yeah, and even in kind of the lead up to this podcast, it was kind of sprinkled in that it would be a little bit in terms of like ethical dilemmas or ethical changes or the differences between your ethics and what a hospital does. And really and truly, like I want to start by saying a hospital is outside of politics. And has its own ethics. There's various things that you and I have done, and doctors, we have oaths that we say that are meant to be very patient-focused in the healing and health of a patient.
Right.
So the reason why this was even a kind of a topic that I even started to think about was one of my hucks came to me and was like, hey, Christopher, I just have a question about what I should do if ICE decides to come to the unit. And I sat and I looked at this huck and was like, I have no clue.
Yeah. And then Christopher texted me.
Yeah, because I was like, oh, Colby's got to know.
And I was like, good question. Like, excellent question by our Huck, and I don't have an answer. Like, I don't know. And we haven't gotten any instruction or there's been no conversation about it at our healthcare system. So we all kind of just looked at each other like unsure. Guess we have to do our own research.
Yeah. Yeah. And it's unfortunate because that question was asked like 2 weeks ago. And we've still yet to hear something about it. Though now that I've kind of done some research and I am no way a like expert on any of this. And I do want to say that the views and thoughts and opinions expressed by both Colby and I are solely ours and don't reflect or represent any of our employers. And this podcast is for informational entertainment purposes only and should not be considered professional, medical, or legal advice. And that's being said because I want us to be open and honest in this conversation because we want to be just as real with each other as we are with y'all. And that's a way to kind of cover ourselves so that we can be. But what does it mean for, I guess, really and truly kind of to make you aware as a listener, since the change in political leadership, there has been a increase in deportation of illegal immigrants,
Mhm.
specifically criminal illegal immigrants. But as multiple news sources have said, there are quote unquote collateral people that have also been deported, children,
Families. Mm.
And this overall was being done outside of safe havens like churches and schools and hospitals.
Right.
But with the newest
administration,
thank you, there has been a release to be able to go into those specific safe haven areas. So what does that mean for you as a hospital?
Hospital.
Yeah, we'll start with hospital and we'll narrow down to healthcare and nurses specifically.
Okay.
So, like I said, hospitals are a safe haven.
Mm-hmm.
What do you think that, in your words, what do you think kind of like a hospital being a safe haven means?
Okay, so basically my interpretation of a hospital being a safe haven is a place where, obviously specifically the hospital, if someone is in need of medical attention despite their status, whether they're illegal or an illegal immigrant or natural born citizen, that they can come there and get the service that they need, medical service that they need.
Right.
Without questions being asked, without insurance being necessary, without a means to pay. It doesn't matter. That's the place where you can get the care you need.
Yeah, and that this is broader than just the topic that we're talking about right now. Black, white, Asian, Hispanic, like it doesn't matter what creed, color,
and
status,
it doesn't have to be like, it has nothing to do with your race. It has, it can be like a disability that you have. Like it's no discrimination,
right?
And you're going to be provided the care that you need.
Healthcare is healthcare, no matter what.
Yeah, and
that's the kind of main bucket that I want us to kind of keep our eyes looking through that lens is. Healthcare is being provided by a hospital, and healthcare doesn't matter. Everybody gets sick.
Right.
Everybody caught COVID. Everybody catches the flu. At some point in your life, you get older, your body breaks down. It starts to get, like, these things happen. Unfortunately, even now, as a Black male who works in the healthcare system, I have to be very conscious of the Tuskegee Experiment, Henrietta Lacks. These were just within 200 years of right now that these things happened in healthcare. And we are experiencing these transitions and shifts into growing a healthcare system that is equitable for all.
Right.
And, DEI has also been kind of pulled out. And man, I did not expect to talk about that. But DEI
it's all connected,
is all connected. Yeah. It really is.
Yeah.
And that is, yes, this is the lens that I want us to kind of focus on because it doesn't matter. It doesn't matter. But another thing is we have, as a healthcare system, any healthcare system, something called HIPAA.
Right. This is throughout the whole U.S. This is a federal agreement that was made to protect patient information.
Right. And a lot of the times you might hear us say PHI, P as in Paul, H as in hot, I as in integrity, but it's patient health information. And that's a lot of words, so I'm probably going to say PHI a lot. But PHI is what HIPAA protects. It allows you as a healthcare provider, a hospital, to ensure that you don't flippantly give information to those that ask just because they ask.
Correct.
And it allows you, as someone who goes to the hospital, to know that your care is going to be taken in a very secure manner, and you're just going to be focused on, and yes, it has to go to your insurance, but they only give a certain amount of information. It's only what's asked.
Right.
It's not like, I went running 30 miles and tripped on a tree and broke my knee. I mean, they just will say,
broken knee.
a broken knee, right? Like the stories that you give us and tell us and confide in stays within us. With all that, the left lens is your ability to be a safe haven, healthcare for all, equitable, and then the right lens is
maintain professional and patient privacy.
Yeah, we kind of setting the stage there, right? Now, what is ICE, and what's the difference between ICE and the police?
This is a tricky one because I feel like there's a lot of question, and I think that's like where a lot of confusion stems from, especially how certain entities present themselves.
Mm-hmm.
And that's kind of like a tactic, whereas like where a police officer and someone who works for ICE, they can look very similar. If you think about like most people's perception of law enforcement, I would say starts with media, and whether that's like a TV show or the news or whatever.
Yeah.
You may see like FBI, they wear jackets that say FBI on the back. Like you're going to see an ICE individual wearing probably clothes that say ICE on the back. And so like it's a very like gray, blurry line at first like assessment. And so it can cause a lot of confusion. What is the definition of ICE? What does ICE stand for?
So ICE stands for U.S. Immigration and Customs Enforcement.
It's a federal agency that enforces laws related to immigration, customs, trade, and border control.
Right. And I mean, it was created in 2003 and has been something that has helped reduce immigration illegally.
Mm-hmm.
And actually, I mean, it's monitored legal immigration too. So those things it's good. And 100%, I understand the importance of this branch of government.
For sure.
But going back to the lenses, we can't allow healthcare to be tainted by something just because a person is sick and isn't supposed to be here.
Right. And I do think maybe part of the issue of why we haven't discussed it at our health system is that we do live in a quote unquote like white bubble. And I don't think that that's smart to ignore it until it becomes a problem. But I do think that's a part of the issue. I think it's just like it has everything to do with the location. And I've worked in other hospitals in our state where they were more metropolitan, and there is way more variety. I think it's just because of our location in our state, and I don't really know that there's a real excuse for it, but it is the truth. And so I think that it kind of issues and topics like this kind of get put on the wayside because it's not in the forefront of their minds.
Right, which is why we're bringing it up.
Yes.
Because we know that we're not the only healthcare system that is probably allowing this to kind of pass by unless absolutely necessary.
Yeah.
And honestly, the location that we're at, yes, is primarily white, but is actually a fairly big recruitment for those that are trying to come to the United States. Because we are really accepting and really open-minded, but that also puts a target on this particular area because of what ICE is currently doing. And we want to make sure you're aware so that you don't get caught with your tail tucked behind your underneath your leg. I want to ask, what would you do if ICE showed up to your unit?
Well, before I did my research for this podcast, I think I would just call my manager immediately.
Right.
Because like just based off like what I've seen in the media, like there's some question about whether or not how they're going about things is fully legal or it just seems shady. And that's just from the media that I've consumed. You know, like someone else's consumption of media might have been the opposite. They might, give them whatever answers that they want. I do think like you should. Obviously, first line is like, let your management know. I mean,
Right.
you would do that for any kind of law enforcement presence because you're not. I mean, I'm not.
I hope so.
And I'm experienced and have been working on the unit that I'm working on for many years. I have no idea what to do in the case of any form of law enforcement coming. I'd be like, hold on a second. I'd be like, please hold. Let me get my boss
Right.
because
I am not the boss.
I'm not that person, and we will figure this out.
Right.
But after doing some research and learning about like the status of hospitals being quote unquote safe havens and where ICE is allowed to be in, because it is obviously a hospital is a public space, and that's the point of it being a safe haven so that anybody could come and get the care that they needed. They are not allowed in private spaces.
Right.
And so that means like they're not allowed to just like walk onto the unit and like walk into a patient's room and arrest them. Like that's violating their own rules. So if we all like in our health system, every unit is a locked unit and you have to ring a doorbell to get in. So I honestly would be a good question for our leadership is, are units considered private spaces because of that locked door? But even outside of that, like people come in all the time. Someone badges in and then someone walks in behind them, and that's just the nature of having doors like that. So that's not to say that like, oh, I'm not going to worry about this because this unit is a locked unit and so it's a private space, so they shouldn't be here. Like they could still walk in, and then what are you going to do?
Right.
So having the awareness that like they are not allowed to come into a patient room, you can tell them that. Again, like you don't want to put yourself in harm's way, and you just don't know like how intense these situations and interactions could get. So I always would say reach out to your manager, call security for the hospital.
Right.
You could call the police. A lot of times, I can't say a lot of times because I don't really know, but I feel what I have seen and consumed in the media is that what they're supposed to do is to have updated the local law enforcement or police. So it would be a coordinated event. And what I have actually seen on media is that they are not doing that. So I think it would be beneficial for you and your patients to also make contact with the local law enforcement if they were to come onto your unit.
Yeah. And, I'm going to address a couple of things that you had said in terms of the unit being a private space. From what I was kind of deducing from reading a lot of different things, it seemed like a unit was a private spot.
Yeah.
Like they're not even really supposed to come onto the unit.
Right.
Now,
a lobby.
Yes, they can come into the lobby, which a lot of patient family members stay in that lobby, which then that patient family member is interrogated, and like unfortunately we have no control over that. They can go to the cafeteria, they can go to like the bathrooms because those are public too. But I also think, to what you were saying, it's very easy to have, someone badge in and then the door opens but now I think this shows that we just have to be extra diligent to be like, I'm sorry, you don't have a pass to come through. You must ring the doorbell to get in. And I think really and truly, like I said, focusing on encouraging and empowering people to say, I'm sorry, your badge. One, we as in our healthcare system are supposed to have our badge visible at all points of us being in the hospital. If we don't have our badge, we actually are supposed to go get a temporary badge, pay $20 to get a temporary badge so that we can be in compliance in terms of our dress code. We don't really have one.
It's also part of JCO that we have to have name tags and like what our rules are.
Okay.
Yeah. So JCO requirement as well.
That's good to know. That's done for a reason, specifically like this one. Like you can say, I'm sorry, you do not have a badge. Please go get a visiting badge downstairs at our front desk, and we will gladly be able to assist you after that. In terms of being cautious when or if they do access your hospital, if you impede them or hide the person or try to help escape the person they are looking for, that is a criminal offense. Do not do that. Yes, I care about all people, but you unfortunately have to be a little selfish here because you've got to make a living too. And that doesn't make it easy to kind of sit back and kind of see what's going on.
Mm-hmm.
But like I said, if you are able to have them stop at the door, you can have them stop at the door. Like, you don't have to let them in. You don't let any other patient family member that doesn't have the right information in. That is the same. That is not different. That you're not making an extreme case to prevent them from coming in.
Right. They need to have like they come in, let's see they get through. Like there are requirements for them there's paperwork requirements for them to be there if they're going to act on being there. So you as a healthcare provider can ask to see the warrant, and if it's not like if they don't have one, then they don't have a legal right to be on the unit. Like they would need to leave, in which case is why it's important for you to contact your management and security and local police.
And that warrant needs to be judge appointed and judge signed.
Yeah.
Like, it's very specific.
It is. And there are different kinds of warrants. So again, it's important to have local police, your security and management there so that is appropriately scrutinized, I guess you'd say, to make sure that they have the correct documentation. Yeah.
Yeah. And when you reach out to your management, I mean, I'm going to be honest, somebody reached out to me, right? Mm-hmm. And I had no clue. So I had to reach out to my director because I was like, I don't know what I'm doing. Mm-hmm. And I did not learn this in nursing school.
Yeah, I wasn't prepared.
Right? And so even our director was like, yeah, this is something that is definitely new, right? Mm-hmm. It's just like COVID. You're constantly learning. We had to adjust. We had to pivot. Now we're adjusting and pivoting to this new political climate that we are in right now. And he was saying, like, don't hesitate to reach out. Mm-hmm. And I feel like I was doing some research and there were, as a hospital, because we haven't quite narrowed down to the like specific role of a nurse, as a hospital, hospitals need to make an action plan. They need to have they already have people that have like an action team for snow, an action team for
mass casualty,
an action team for all these different things. We now need an action team for ICE and deportation involvement.
Yeah.
And that team needs to include security. Mm-hmm. It needs to include a spokesperson that talks to like the media and news. It also needs to include someone that we can reach out to, we as in the frontline staff. Mm-hmm. Because yes, the managers, we do want to be involved. We want to be aware and know what's going on. But we can only do what our unit can, we only have the control of our unit. What if ICE decides to go to some other unit? Like, we're going to have all this whole slew of managers trying to bond together when we can all have one person that kind of is funneled through. And then you can be like, to the ICE enforcement agent, that you can say, oh yes, let me get this particular person that deals with this specifically, and allows it to kind of deflect that responsibility off of you. Mm-hmm. Now, as a nurse, do you remember doing the Nightingale Pledge?
I think at our pinning ceremony, we might have done that.
Do you remember it?
No.
Okay.
It goes the one and only time.
So it is very, it's known that the Nightingale Pledge is like the pledge for nurses. It's like the Hippocratic Oath for
doctors.
For doctors is for nurses. And I do want to read it because it is important. And it says, I solemnly pledge myself before God and in the presence of this assembly to pass my life in purity and to practice my profession faithfully. I will abstain from whatever is deleterious and mischievous, and will not take or knowingly administer any harmful drug. I will do all in my power to maintain and elevate the standard of my profession, and will hold in confidence all personal matters committed to my keeping, and all family affairs coming to my knowledge in the practice of my calling. With loyalty will I endeavor to aid the physician in his work and devote myself to the welfare of those committed to my care. So the main part I want to focus on is I will hold in confidence all personal matters committed to my keeping, and all family affairs coming to my knowledge in the practice of my calling, and then to devote myself to the welfare of those committed to my care.
Yes. It all comes down to it doesn't matter who or what the patient is or what
Right.
they need. It matters that they're getting the care that
Right.
they are looking for, they're requesting.
Right. Welfare of those committed to my we're ensuring that they are going to leave the hospital better than when they came.
Right.
That is what we as nurses are supposed to do. Now, it's hard because there are people that are politically, they lean more to the left. Or there are some that politically lean more to the right. That happens, but you can't allow that to deter or change the way you give care to a individual.
Mm-hmm.
You have to see that individual as yourself, or as your grandmother, or as your father,
Mm-hmm.
or as your sibling, and you would not want detriment to be done to them in a safe place where they have, I mean, there's some literally you wipe people's butts because they cannot do it.
Mm-hmm. I think it's the same sentiment as like when we're treating an inmate from a prison or jail.
Ooh, yeah.
Like we are not giving that patient any less care than what we would someone who just walked off the street, like, or it is a friend or a family member. Like, it doesn't matter why they're in jail. They could have done something absolutely heinous. But if they're there for a medical reason, they are there for a medical reason.
Mhm.
You're providing the medical care. It's we are supposed to be unbiased. We are supposed to just do our jobs and help a patient become healthy and get them on their way. Like, that's solely our position here.
Right. And really and truly, it is not your business if they are, unfortunately, it's a little easier to see if they're an inmate, but it's not your business if they are an illegal immigrant.
Mm-hmm.
It's not. You don't need to know that. And really and truly shouldn't know that, because unless they have confided in you, which, good job for you.
This brings up an interesting case or topic, sideline. Our health system in our state does not require that we ask a person's immigration status when they get admitted, but there are 2 states in the U.S. that have made it a requirement that they ask on it, like as part of their admission documentation. So some people don't have some people don't have the ability not to ask, but one tip would be that, like, if you don't live in one of those 2 states, so you're not inquiring, like, just ask what you need to know.
Right.
I will say, like, I've taken care of, or at least have had them on the unit, at least like 5 in the last year of patients who were illegal immigrants to the U.S. and they had heart issues, and we discovered that they were not legal immigrants when we started working them up for like an LVAD or a heart transplant. Right. And then that became
a whole thing,
like a huge stopping point, because we would need to like investigate further about like how we could get them on like Medicaid and all that stuff. So it's very tricky, but I think if you're lucky enough to live in a state, outside of the 2 states that require the hospitals to ask patients about their immigration status, don't ask.
Yeah,
it's not
just don't
necessary.
do it.
And if it comes up in conversation, I wouldn't document it anywhere, because it shouldn't change how you're providing care.
Right. And I mean, interestingly enough, we've given kidneys to,
Yeah.
and I mean, and
We've put a heart in
Right.
an illegal immigrant, but they were going to die without a heart
Right.
transplant.
because their life is important.
Yeah.
That's what it boils down to. It's like, are you really allowing somebody's life to possibly die just because they're not here in the United States?
Right. I
Like-
think that change, like your focus for your as an individual and your role, like you're not focusing on the right thing.
No, not at all. And so what should you do as a nurse? You should make sure you're educating yourself. Like
Mhm.
Colby and I took some time, and this was a, just being transparent, this was a pivot from the original scheduled
Episode to record.
to record. This was not one that we had worked up a couple of weeks ago, but literally, I mean, it took us a couple of days, and we did research. We looked, and I was like, Colby, I don't think we can record it yesterday because I don't think I'm ready. I don't think I'm ready to get it out there, and I want to make sure we're at least somewhat knowledgeable on the topic, at least a little bit, to kind of help start the conversation.
Mhm.
And luckily, Colby agreed, because I was like, oh, good, because I'm not ready.
Yeah. I still don't feel totally ready, and I would like to just like reiterate that this is like in no form or fashion like actual legal advice or anything,
Right.
but just like more of like a plea to do your own research and to like empower yourself with some knowledge on the subject in the case that you do run into this situation, because I feel like at this point it's just a matter of time. Like it's a ticking clock. Like
Right.
like I said before, like even being in a quote unquote like white bubble where we are, we both have had patients where of illegal immigrant status and provided care to them. So
Right.
it doesn't matter if you live in a metropolitan area and 90% of your patients could be illegal immigrants. It doesn't matter if maybe 1% of them are. Like, it truly could happen, like the situation like where ICE agents are in your hospital, to anybody, anywhere, at any point. And it's important to empower yourself, is really like the hot word, is empower yourself with the knowledge to know what to do in the case that it happens.
Yeah. And then go ahead and educate your patient. Like,
Yeah.
we no matter what, you are still an educator. If it's not only to yourself, it's to the patients you provide. If
Mhm.
they do confide in you that they are an illegal immigrant, go ahead and read them the rights to remain silent when they are being arrested.
Something I did come across that I found interesting yesterday was like, while they have the right to a lawyer, the government is not required to provide one for free. So because of their illegal status,
Oh.
but there are law groups out there that provide this service at like low fees or no cost. So I feel like if you do know that your patient is an illegal immigrant, and in these certain climates right now that we're in, I would encourage them to just be prepared in the back of their mind. Like,
Right.
if you are able to establish a rapport with a patient on that level, or like have a conversation with like a social worker who might be able to direct them, I think just like, again, empowering them with the knowledge of what rights they have is super important.
Yeah. So what happens if we kind of stand firm on the two lenses that we talked about, the fact that we are a safe haven and we do confide in the information we do provide a safe place and hold dear the information that we are given, and we don't allow kind of politics to influence our decision as a healthcare system?
Mm-hmm. What exactly, if we're staying within that lens, and we are forced into a situation, what are our rights? What are we doing?
Yeah.
We already touched on it, but like warrants and consent, they can, like, unless they have a warrant that's specifically signed by a judge or magistrate for a specific identified individual, they don't have a right to be there. We as health caregivers have a right to remain silent. They could ask us questions and you can say, I don't know anything about that. Like, I don't have anything to share on that.
Mhm.
I don't have anything to say. I cannot answer that question. I'm sorry, I don't know the answer. Like, you have the right to remain silent. And this is all stuff coming straight from National Immigration Law Center's webpage, which you guys can go check out, to some of the websites that we used for our research in the podcast. And I strongly encourage you all to kind of take a look at them as well. Like, we did the heavy lifting for you. Just read it. Like, we'll put it all in one spot for you.
Right.
They have the awareness that they have rights to look at anything that's in plain view. So if they have a name of a patient, like for instance, on our units, we call them grease boards, but they're like they're on large television screens, and it'll have like patient's last name, like the nurse assigned, the team assigned, and like a couple other things. So that way, if like a consult comes, they're like, hey, who has this patient? We can direct them to the board, that sort of thing. So like anything that's in plain view, they have the right to like go up and look and just know that. So don't try to impede or like get in the way of that.
Right.
Again, back to the private areas, like only authorized persons are allowed to enter private areas. And I think under the interpretation of how our units are at our facility, they are locked units.
Right.
And that means in order to get in, you need to be an authorized individual, or you need to be an authorized individual okaying someone to come in. So we are allowed to not okay someone to come in, basically. Like, we can say yes or no because we are the authorized individuals. Now, if they're standing there at the camera with a warrant, we may want to investigate that further because, again, you don't want to impede or get in the way of that legal action.
And I mean, really and truly, sorry, I'm going to interrupt just for clarity. These cameras aren't like 4K zoomable. So like you can say, that looks like a warrant. I'm going to get the proper people to come and
they can
ensure
meet
that
you outside the unit.
Right.
I will call security and local police, and they will meet you outside the unit. Because that's unimpeding. That's saying, okay, we will get someone to check that.
Yep. And do it.
And and then actually do it. Yeah. Again, because you don't want to be accused and then arrested yourself.
Right.
Things to look for in the warrant. Is it a valid judicial warrant? Is it signed by a judge or magistrate judge? It states the address of the specific premises to be searched. So they may come to your unit and it may have the patient's name on it, but what if it's not the hospital's address? Then this is not the place where they had a warrant to search.
Right.
So that's also, that's key right there. And is it being executed during the time period specified on the warrant? So these are small little things to just keep your eye on that could easily be missed if you just see like, oh, the judge signed it.
Right.
Again, hopefully you as a bedside nurse aren't the one that's scrutinizing this document, because that's a lot of pressure. And it's not really in our jurisdiction or anything like that. Hopefully the powers that be in security, local police, or at the very least your management, like they're the ones. But just having awareness, again, is empowering you.
Yeah, your job description does not include that.
No, and not at all. And then it goes a little bit deeper about like the scope of the warrant, and then the definition of probable cause, and what the probable cause could be for a possible legal immigrant patient.
Overall, it's a very good article to read.
Yeah. And those were the bullet points. It goes even deeper. It's a very informative.org, and I highly recommend, just at the very least, like there's an insane amount of information, but they have like information cards, like something that, makes it very quick for you to see. Like you can go to this link that we will provide and you'll get just a wealth of information.
Yeah. And I just want to kind of end this part of it by saying, this is what's going to happen if we stand firm to all of that. We continue to have a safe haven for those that need health care. And that includes those that will already might have slight hesitations toward health care, and shows, this, if a health system stands up to this, you will be on the news.
Mm-hmm.
You will. And that's going to show other people that they know this health system is not about the money, because really and truly, I'm being a positive and a negative here. Illegal immigrants do not pay us.
That's true. Taxpayers pay the cost of their care.
Right. And that means, unfortunately, that That's you and that's me.
Mm-hmm.
And that's you as a listener paying for that person's healthcare.
Right.
But
I would also, before we go further, would like to just like make one point where
Mhm.
it's a little bit different, but could be interpreted similarly. Is like the idea, like we have to have something in place where, like, if there was somebody that was here that is not a legal citizen of the U.S., it could be like reframe it in your mind as like you went on vacation to Europe and you broke your ankle
Yeah.
falling on a cobblestone road,
Yeah.
and you go to their hospital. It's very low to no cost
right.
for that, for us, because the way their government also covers like people who don't live there and don't have their insurance or on their social, like, because it's all set up different than from the US, but like they are all like, their government is also paying for what would be some of your healthcare over there. So if you frame it like more in that, like, oh, they're illegal immigrants, they shouldn't be here, we're paying for them, like sometimes things just happen.
Yeah.
Like they could be illegal immigrants, but like working their tails off and like contributing in that sense, like to in taxes and whatnot, and still require health care.
Yeah.
Like, I don't know, but I just wanted to frame it in a little bit. Maybe one way that other people who are initially like, this is crazy or this is bullshit, like just reframe it a little bit so that they can see it from a different perspective.
Yeah, I didn't think about it like that. That's a good way to kind of reframe that perspective.
Mm-hmm.
Now, if we don't uphold to our lenses that we are saying, what happens? It leads to, interestingly enough, more widespread common illnesses, cold, flu, COVID, pneumonia. These things start to spread more often. Why? Because we have demolished the trust that we had tried to build as a healthcare system.
Right. Communities of people are not going to come to the hospital for help when they're sick. And instead of providing like public health to people, they're going to be spreading it amongst themselves spreading it further. It's like a domino effect.
It is. Mothers are not going to come to the hospital. So increased risk of fetal death, maternal or maternal death. Emergencies aren't going to happen, so that increases
I would argue to say that like there's going to be more emergencies. I would argue that because if people are waiting until the last possible reason to come get health care because they're terrified or distrustful of it, like you're going to be dealing with an even more expensive problem because it's going to require ICU level care or insane surgeries or transplants or of organs, like all of that stuff. I would say when we break down that trust in our communities, it's going to become more costly. It's going to become more tiring, like for staff.
Right.
It's a terrible domino effect.
It is. And going to the staff topic, there's possible staff turnover that will increase.
Yeah, I could imagine burnout.
I mean, who knows? I don't know Joe's wife's immigration status.
Yeah.
Now, Joe might have a very valid reason for being here and could possibly be here legally, but his wife might not, and ICE might come in to try to interrogate Joe, and Joe might have to leave.
Yeah. I mean, that's an extreme example, but not out of the realm of possibilities.
No.
At all.
All right, it's time for pop quiz.
Let's lighten it up a little bit.
Yeah.
Okay.
We need this.
So, pop quiz is ethics and nursing. Kind of goes with our theme of topic here today. So, all right, y'all. It's time for another pop quiz. Let's test our ethical decision-making skills with some NCLEX-style questions. Get ready.
Question number 1. Patient autonomy versus family wishes. A 68-year-old patient with end-stage renal disease has signed a do not resuscitate, also known as DNR, order. The patient's family arrives and insists that everything possible be done to save their loved one if their condition worsens. The patient is unconscious and unable to communicate. What's the best course of action? A. Follow the family's wishes and initiate resuscitation if necessary. B. Explain to the family that their wishes override the patient's directive. C. Adhere to the DNR order and educate the family on patient autonomy. And D. Contact the provider and ask them to revoke the DNR order.
All right, think about it and lock in your answers. The correct answer. So the correct answer is C. C was adhere to the DNR order and educate the family on patient autonomy. The nurse must honor the patient's advance directive or DNR order and educate the family about autonomy and decision-making. Patient's wishes take precedence over family demands. So even while the patient was unconscious and unable to communicate, they made a legal document when they were conscious and able to communicate and make sound decision, and for the exact occasion that this was to happen.
Right. And it's not easy. I'm gonna be honest. I absolutely hate DNR orders, and I have to fight every day I see one. Not to and it's not like I do it on a regular, but I'm like, I want to do something.
It's in our nature as healthcare providers to want to make a difference and to turn around someone's health. And so it is tricky. It's all about ethics and legalities and end-of-life care. Nurses have a duty to follow advanced directives even when emotions are running high. I think that's a very good quote. But yeah, it is our, part of delivering care is following patient wishes.
Yeah, but the thing is, we have seen people talk patients out of a different status.
Yeah. Again, and why most hospitals, if not all hospitals, have an ethics team, because personal opinions can sometimes bleed in, even though it's our duty to not do that and provide unbiased care like we've talked about. When emotions run high, they can bleed into one another. And so that's when you bring it to the ethics team, and they kind of look at it from an outside perspective and can kind of bring your focus back in on what the patient wanted.
Right.
And what is truly the best decision for the patient. Yeah,
go ahead and just familiarize yourself to the ethics team of your hospital, because the majority do have one.
Mm-hmm. Okay, so question 2, medication error and ethical responsibility. A nurse administers the wrong dose of insulin to a diabetic patient and realizes the mistake immediately after the injection. The patient's blood glucose is normal and they're not showing symptoms ... yet. Okay. What is the nurse's next best action? A. Monitor the patient closely but avoid documenting the error to protect themselves. B. Report the error to the charge nurse and provider immediately. C. Wait until the patient develops symptoms before notifying anyone. D. Ask a colleague to co-sign the chart without mentioning the incorrect dose.
All right. Think fast. Ethics and accountability matter here.
So, correct answer is B. The nurse must immediately report the medication error to the charge nurse and provider to ensure patient safety. Veracity, which is also known as truth-telling, and accountability are essential in nursing practice. This is a big one, guys. Transparency is everything in nursing. Hiding an error is never the right choice. Reporting mistakes prevents harm and protects patients.
Yeah, and we had briefly talked about me messing up the heparin, and there are times where you make a mistake. You are human. You're not a robot, and it's okay. And I know our healthcare system has a way to report these things as a non-punitive way of making sure workflows and processes are done efficiently and to prevent error from happening. that's okay to report yourself. It is fine. It's actually, I feel like, a very big and bold move for you to say I messed up.
Yeah, it is. I feel like, and everyone's done it.
Mm-hmm.
So don't be like, don't hide it, whatever you do.
Yeah.
Everyone's made a mistake. I've made a mistake, and I wanted to save it for the next time we did woes and wins, but I will share because it goes on topic where I actually did administer the wrong dose of a medication.
Like of insulin?
No, not of insulin, thankfully. But it was pain medication, actually. I was giving, I think it was either morphine or Dilaudid, and the patient was like in so much pain, and the order was like 1 milligram every 3 hours. And I finally got the team to increase the dose to 2 milligrams. And I, like, out of habit, because I'd been giving it every 3 hours, just pulled, and I didn't, so I just pulled 2 syringes because they were 1 milligram syringes that were getting put out.
Yeah.
And so I gave I scanned it, but I was in a rush, and there was like a window popped up, and I just like overrode it, didn't read it. So again, like not following my 5 rights, but that's what happened. And I gave accidentally 4 milligrams of morphine instead of 2, because when the pocket opened, it actually opened up a different pocket, and it was 2 milligram syringes, not the 1 milligram that I had been giving all day. So then the patient was like feeling great after that.
Good.
But I did like immediately tell the provider and our charge nurse, and was like, hey, I messed up. Actually, I didn't even realize I messed up at that point. Now that it's all coming back to me, they were doing a narc count, and there was a narc missing. And they were like, what happened? And I said, oh my God. I still had them both in my pocket, so I could show. Yeah. And I was like, I gave him 4 milligrams. No wonder why he's totally fine now. I was like, holy shit. And like that sinking pit feeling that you get like in the center of your chest or in your stomach, like you're like, oh my God. Like, I cannot believe I did that. I wrote up, the non-punitive, thank you, like form online, and like explained what happened, and it all made sense. And I knew that, and I talked about it with my manager. We had like a very brief meeting about it where I was like, yeah, I simply did not follow the 5 rights. And obviously it's so important that we do it. And I was running around. The patient had been screaming in pain all day. And I had 3 other patients that were busy doing other things. And I just didn't think about it. And luckily there was no harm to the patient. In fact, it actually helped the patient more than what we were doing. And now that I think about it, that patient was actually an inmate as well. So double whammy with the medication error and them being like a DEI.
Yeah. So, wow.
Yeah. So there's a bonus nurse woe for you.
Yay! Guys. I do appreciate that. All right, man. Ethics can really be tricky, but at the end of the day, it comes down to honoring patient rights, owning mistakes, and always prioritizing safety.
Yeah, absolutely. And if y'all want more NCLEX style questions and deep dives on real world nursing dilemmas, let us know. Maybe we'll do a full ethics special.
Ugh.
That's kind of what we're doing, though.
Yeah, I mean, on 2 specific things, but yeah.
It's very deep.
Hit us up on Twitter, on YouTube, on Facebook,
Instagram,
and if you want to hop up on our Patreon, we have that too. And tell us how you did on today's quiz. Would you have picked the right answer? Our last topic isn't going to be as long as the first one because, one, I feel like it is very difficult and it is very specific.
It could be very polarizing.
Yeah, but...
Which is wild to say because I feel like this whole episode has probably been very polarizing for people, but this goes even a little bit deeper, I think.
I think this one's a lot worse in terms of polarizing than the current political administration released an executive order that is meant for the entire country and medical professionals, and was stating that they're maiming and sterilizing a growing number of impressionable children under the radical and false claim that adults can change a child's sex through a series of irreversible medical interventions. This dangerous trend will be a stain on our nation's history, and it must end. Countless children soon regret that they have been mutilated and begin to grasp the horrifying tragedy that they will never be able to conceive children of their own or nurture their children through breastfeeding. Moreover, these vulnerable youths' medical bills may rise throughout their lifetime, as they are often trapped with lifelong medical complications, a losing war with their own bodies, and tragically sterilization. Accordingly, it is the policy of the United States that it will not fund, sponsor, promote, assist, or support the so-called transition of a child from one sex to another, and it will rigorously enforce all laws that prohibit or limit these destructive and life-altering procedures. I want to be the first to say that I grew up a man of faith, and I truly believe in the Christian background that I grew up in. But now that I've been in healthcare, I can't stand behind this.
Yeah.
And I think really and truly it's because I also know that there are, and they're not talking about this in this situation, I don't believe, but there is very few areas that you can say a person. There are conditions where people come out of the womb, both male and female.
Correct. Mm-hmm.
So, those things happen. And I have seen people go through gender dysphoria. I have seen it and seen how crippling it is to a person.
Mm-hmm.
And it is very difficult for me to quantify what would change in this, and I don't know, and it's not easy. It isn't, but my initial thoughts are I can't allow this to be something that is influencing our way of healthcare.
Yeah.
I mean, it's been so much so that even our state's attorney general was like, us as a healthcare system are not allowed to do these surgeries anymore.
Mm-hmm.
And there was a protest. There was a peaceful protest out there a couple of days after that announcement from the attorney general.
Mm-hmm.
What are your initial thoughts?
I think my initial thoughts on reading this is whoa. It's very reminiscent of the beginning stages of controlling individuals. It's reminiscent of your sexual orientation diverting from the quote unquote and what they define as normal, or being in the DSM. It's very it's giving sliding backwards.
Yeah.
In our progress as acceptance of how different people want to live different lives.
Yeah.
I think I'm also torn though, because they're specifically talking about children.
Yeah.
And so it's on one hand I can see and understand, but it's the undertone of what they're if you're reading between the lines situation, where I'm this isn't good. But at the same time I'm these are children who brains are not fully developed yet. So maybe making really big decisions surgical aspects or stuff like that, maybe that's not the best idea at these young ages. But also, it's not my decision to make. I don't know. It's such a sticky. It would definitely be something that I would need more information on. my initial thoughts, I don't support this.
Right. Yeah. And
I have more questions.
Yeah, I think, and that's what this brings up more questions than I think in terms of just being okay with it. I 100% agree with you, Colby. It's the fact that they have narrowed it down to children, and their definition of children are individuals under the age of 19
Which is
years
also
of age.
Confusing, because if you're a legal adult at 18,
yeah,
why wouldn't they say 18? Why did they choose 19?
Right.
If we can go out to war at 18, why can't they make a decision about changing their gender at 18?
I don't know. And
Weird.
you know, and that's, you know,
That gets me on a soapbox, but okay.
well, and this is like, this is real. This is what we are struggling with as nurses inside of healthcare.
Mm-hmm.
And I know other people are too. And like, I'm struggling with it different than you are because of our different backgrounds. Like, you know, it's different. But I mean, I remember I see the person's face. They preferred the pronouns he, him. And I remember going into their room and he was like, your colleagues are not acknowledging my
wishes,
my preference.
Yeah.
And I'm like, I was not an A&M at the time. I was still a Clin 1. And I'm like, I don't even know what to do. Like, I don't know how to say I'm sorry. Like, I don't, like, I'm sorry is so flippant.
Yeah. Mm-hmm.
Like, I prefer.
It doesn't feel sincere when it's.
Right.
Even if it's coming like from a very sincere place, it doesn't feel like it will be interpreted as sincere.
No. And it's like, I mean, I went out to the charge nurse and was like, hey, this particular room prefers pronouns he, him. Is there any way that we can, like,
make a note of that,
like change how we're addressing him? Like, it's.
Was this before our health system made strides in changing the documentation? Yeah. So we now, and it is probably more recent in the last like 5 or 6 years, where we can add stuff like that in their little like name, date of birth, pronouns. Like, we can change that information where 5 or 6 years ago we were not able to. It was only like how someone was, like what they came out of the womb with. Like, as far as that goes, there were no preferences or abilities to make changes.
And it really.
But this, I feel like this executive order is the beginning of a slippery slope where they walk that back. Like, they're already, this is kind of off topic, but with the current administration, like removing anything that has to do with DEI, that also includes that I've seen reports of making staff of federal departments remove pronouns from like their own personal profiles.
Yeah.
But yeah, I think if we're already making federal employees lose their pronouns preferences in their email sign out or just in their profiles, like, at what point are they going to put out an executive order that says, like, we're not allowed to use personal pronoun preferences in patient charts?
Yeah. We don't
know. That's the thing.
I don't. Yeah. But I mean, you know, I'm going to be kind of along the DEI like track. My vegan aunt, Tabitha Brown, she's not endorsing any of this, but she's not really my aunt either, unfortunately.
But we do love her.
We do love her, though. She had to do a Patreon of like, hey, I see what's going on, and Tabitha Brown has gone into Target and was like all into Target. And if you don't know Tabitha Brown, she's a black lady. She's vegan. That's all you need to know, really. She's amazing. But she's like, luckily she has a contract with Target, so they can't pull that contract.
Mm-hmm.
But other people were not that fortunate, and they're starting to pull those things away. And it's like,
what?
It's wild. It's like wild.
See, and like the greater public probably doesn't even know that. Like, I would never know that if you had not shared that with me.
But there's other companies that are doing this just because of this executive order that this current administration has put out. I'm like, are you kidding me? And you know, and we're in the month of February. This is going to be releasing in the month of February. I'm not a Malcolm X. I don't go just tirading, showing that I'm black and black. I am very proud that I'm black, but I'm not boisterous about that. But I ensure that in February, I'm watching all kinds of black media. Mm-hmm. I'm watching all types of black TV shows. I'm funding all types of black businesses. Now, I should do that, and and I can hear people saying, why are you not doing it for the rest of the year?
You do.
I do.
Yeah.
Yeah, I do. But I make sure to go above and beyond in February because
it's Black History Month.
It's Black History Month.
But this topic brings up a lot of things that it as I said before, is a very slippery slope. And how much are we going to lose?
Yeah.
As a society, as American people, how much are we going to lose? How much are we willing to lose?
Right.
It's very scary times.
Yeah. Man, this is not easy.
Not easy at all. But we did feel like it was super important to at least start the conversation, encourage you to educate yourselves.
Yeah. All right.
I feel like we need like a moment of silence. It feels like we're grieving.
God.
It really is, though, in some form or fashion. But
I'm gonna go to sleep after this.
Yeah,
Take
this
a nap.
took emotionally a lot out of me. But I am happy that we're doing it. I feel like we made a good choice in deciding to share this episode, create this episode, and share this episode with you all.
Yeah, but I'm gonna just kind of throw out. We're recording this on a Saturday. It releases this next Wednesday. So that's how important we thought this was. I already had what we were planning on releasing posted, ready to go. Colby and I decided to push that back because this was more important.
Yeah. Yeah, when Christopher texted me and said, I think that we need to have, maybe we should like do a episode before the rest about ICE and everything that's been going on. I didn't even hesitate. I immediately texted him back and said, yeah, I agree. Let's do it.
So.
All right. Well, we would love to continue the conversation. And I personally, and I know Christopher probably is too, like willing to hear all sides. I think it is important to listen to everybody's opinions and views. It's the only way that you gain perspective in the world. So if you have any thought, feelings, or you want to share, like, our socials are open. Please reach out. If you have questions, same thing. Please look at the links that we're going to include when we post the podcast. There's just like a wealth of information there that could really enlighten you. But otherwise, I think we're ready to wrap it up.
Yeah. Class dismissed. That's a wrap for today's session of Nursing Life 101. We hope you found some useful takeaways to bring back to the floor. Remember, nursing is a lifelong learning journey, and we're here with you.
If you want to connect, find us on Twitter at NurseLife101 or on Facebook at NursingLife101. And don't forget to subscribe and share with fellow nurses. Until next time, keep taking care of yourselves, keep making a difference out there.